pediatric hematologist at Emory University and Children's Healthcare of Atlanta in Georgia. I'm going to talk on congenital TTP, just give a brief overview, and hopefully we'll talk a little bit about the treatment options. These are my disclosures. I do consult and also have received research funding from pharmaceuticals to study hemolytic anemias in general. So what I intend to talk on today will be how all began, talk a little bit about the history of congenital TTP and what leads to TTP. We had some great questions in the previous session. Talk about what is congenital TTP specifically and how is it diagnosed. We'll talk about some of the challenges in the diagnosis of congenital TTP. We'll go through a patient case and some treatment strategies. So almost 100 years ago, in 1923, a patient presented and was described by Dr. Eli Moshkowitz, a physician in New York, about a 16-year-old, a young lady who presented with severe anemia, fever, and had some neurological dysfunction and pain to extremities, and also the laboratory markers was consistent with severe anemia and also kidney injury. The patient actually died in the next 4 to 5 days with multi-organ failure, including stroke and heart failure. And the autopsy, Dr. Moshkowitz's team actually found these blood clots, micro blood clots within the blood vessel, as shown here on the left, within the blood vessels of the heart and also of the kidneys. And it was then thought there was actually a poison which was actually causing this breakdown of these red blood cells and resulting in these clumping of these blood cells within the clumping of the blood cells within the blood vessel. And this was published in 1925. It was not until 1982 by a team of Dr. Joe Moak and others who actually reported on 4 patients with chronic relapsing TTP, who we now know those 4 patients had congenital TTP. And they said that these patients, the plasma from these patients actually had this ultra-large von Willebrand multimers that Dr. Mazeppa was referring to as being Velcro. And they also said there was a missing protein which appeared to actually regulated the size of these large multimers. And subsequently, in subsequent research, they were able to characterize that this missing protein was this ADAMTS13. The way I look at it is the ADAMTS13 is more like a scissor, which actually cleaves, so it actually chops up this large portions of this von Willebrand into smaller fragments. So the idea is that thereby it minimizes the risk of TTP. For those who are interested, ADAMTS13 actually, it's an acronym for this long protein, which I've listed here. So this cartoon kind of depicts on what you expect to happen in TTP. The one on top is what you expect to see in normal. So we have these platelets, which are these little blood cells which are sticking to these von Willebrand factor multimers or the Velcro. And you expect in normal individuals or with normal amounts of ADAMTS13, these enzymes actually cleaves these proteins into smaller fragments, so they just float away and reducing the risk of clumping and subsequent issues. And what we expect is happening in TTP is that there is a lack of this ADAMTS13 for 2 different reasons, which we will address in the next slide. When there's lack of ADAMTS13, these large von Willebrand factor multimers gets even stickier and stickier. There's more platelets clumping, as shown here. It forms this microclots, which actually formed by these multimers and the platelets. And as you expect, that results in the consumption, or the platelet count goes down, as we see in patients with TTP. Additionally, what happens is as these red blood cells are passing through these microclots, what we believe is happening, at least, is that these red blood cells are broken down into these small little fragments of red blood cells, what we call as schistocytes. So schisto in Greek is, it's kind of broken pieces. So, and sites as in cells. So this results in low platelets because they all get consumed in this small little clots. Hemolytic anemia, meaning this breakdown of red blood cells with the presence of schistocytes. And as you can imagine here, this affects the blood flow to various vital organs, resulting in what we call as ischemia or lack of blood flow, resulting in organ injury. So how do we diagnose congenital TTP? So ADAMTS13 activity, when it's less than 10%, we are comfortable to say TTP is confirmed, and oftentimes is usually less than 5%. And then we next step in all the labs do is to look for these antibodies which could be affecting the function of this enzyme or of this ADAMTS13. So the antibody is positive, we call it immune-mediated TTP, which is what's predominantly seen in adults and children. And if the ADAMTS antibody is negative, then we refer to this as congenital TTP, which is a much smaller proportion of patients with TTP. And of course, the genetic testing is needed to confirm a congenital TTP, because some of the nuances of this testing can go either way during an acute episode, right? So this is kind of gives an idea as to how do we decide between congenital and immune-mediated TTP. But what happens in real life is that a patient is presenting with what we call as microangiopathic hemolytic anemia. Essentially is this breakdown of red blood cells, and we look for fragments of these red blood cells under the microscope. If it wasn't the pathologist looking at it, it's usually a hematologist going down to the lab to look at it. And they also have low platelet counts, as we discussed earlier. And they could present with or without an organ injury, because it depends on when they're presenting to you. And this collective term of signs and symptoms, what we call as a thrombotic microangiopathy, or TMA. And once this is thought to be the case, what we ask our providers to think of is send for ADAMTS13 right away and treat immediately. So this is essentially the flow what we expect in real life, especially for somebody who's presenting for the first time. Somebody presenting for relapse, it may be that we may already have a diagnosis. So I'm going to briefly listed some of the other causes of TMA, or thrombotic microangiopathy, and some of this will be discussed later in the day. But it's important, as we discussed today, that the ADAMTS13 activity is expected to be higher than 10% in these cases, such as hemolytic uremic syndrome. We see with, for example, certain toxins, especially in children, could be related to autoimmune disease or cancer, pregnancy, infections, and drugs, and so on. But certainly it's not something that's going to be covered today in my talk, but something to give an idea is that that's the importance of physicians seeing a child or adult presenting with this TMA to think about TTP, but also try to think about other causes which could look like TTP. Again, the symptoms of TTP is not just related to what colors the blood system. As you can imagine, because of this lack of blood supply, it can result in affecting any organs, and predominantly it seems to affect the brain with the multitude of symptoms as I've listed here. The people present with symptoms related to eye, chest pain, and various other heart-related symptoms are actually more and more recognized to be the case. Abdominal symptoms such as pain, nausea, vomiting, especially in patients with congenital TTP, has been well described. We talk a lot about symptoms related to kidneys, such as blood in urine, protein in urine, or just a kidney injury from lack of blood supply or high blood pressure. In patients with congenital TTP and in the immune TTP, there's a lot of general symptoms, which could be just related to anemia, and also because of how other organ functions responds to these anemia and low platelet count. So what are the challenges specifically in the terms of diagnosis of congenital TTP? One is very rare. I've listed here, it's about 0.5 to 2 cases per million. If you look at various different registries, there is a international or Swiss registry, there is a Japanese registry in Norway, so and one in United Kingdom. So so I think of it as about 1 case per million. It's quite significantly rare compared to the immune-mediated TTP, which is also fairly rare. It's about in adults about 3 cases, or in pediatrics about 1 case per 10 million. So that makes it challenging in terms of the rarer they are. There's some of the physicians or hematologists probably have never seen a case of TTP, and they could go through the entire medical career. Other challenges that can be seen in any age group. So immune-mediated TTP tend to peak in 3rd and 4th decades of life, though as a pediatric hematologist, I've seen as young as 6 years of age. But congenital TTP can be seen in any age group. And there are several reports from around the world who have actually very well described what we see these patients with congenital TTP at any age group. And I'm just specifically picked this one from United Kingdom, published not long ago, where they looked at all the patients of about 100 of them, and they looked at the patients that they saw that especially the two major groups were the ones who are neonates, so as in the babies who are usually less than 4 weeks. The medical terminology is neonate or neonatal. So that seems to be forming a significant portion in their group of patients. The second group of patients were the pregnant women. And as you can see here, in spite of those two groups, the age at which they presented varied for almost by 10 years here in the childhood or also in the pregnancy. So it kind of gives you an idea of, because of the fact it presents at any age, sometimes it makes it also challenging in diagnosis. Other key thing is that the age of onset. So you could go on for many years and never have a symptom of congenital TTP, and the people who are present in the newborn period. There's also reports of men and women presenting not till in the very late ages, such as 60 and 70. So here I want to describe a patient's journey which happened in the recent past. I was not directly involved in this patient's care as the treating physician, but I got some permission from my colleague who I helped with into this particular patient. This patient was born outside this country and carried a diagnosis of ITP, which is immune thrombocytopenia. So they have low platelet count and they do not have any other features of TTP. And the challenge is that the prevalence of ITP, it's about 6 per 100,000 compared to 1 in a million congenital TTP. And the patient was treated with immunoglobulin, which we use to help protect the platelets from antibodies so that we tend to make sure they don't get out of the body. And the response to the immunoglobulins, a very commonly used treatment for ITP, can last from a few days to weeks. So the patient actually went through many years with that diagnosis. This patient presented a year after that with symptoms of flu and easy bruising, also started to have heavy period. The platelet count was 6, the hemoglobin was 12. And the patient was again treated with immunoglobulin, thinking that the flu A actually triggered this ITP, and also the patient was suspected to have antibodies also against red blood cells, which again is not a very rare condition in the pediatric age group. Parents actually said her red blood cells are low in the past and always been a slow responder to IVIG. And it appears that the patient had presented during periods of infection. As you can imagine, a child, usually by age of 5, usually goes through multiple different episodes of viruses that they have been exposed to new viruses, and they can present with varying degrees or severity of symptoms. And a year later, a patient actually, after this episode, was closely followed almost every 3 to 6 months. Interestingly, the patient had very normal platelet count. And they also sent out testing for other red blood cell disorders because the patient was thought to break down the red blood cells from antibodies. In early this year, the patient had a fall, broke the kneecap, just the patella, and had some fractures and tore some ligaments. That time, the mother requested for a blood count, which showed a platelet count of about 100 to 150,000. The hemoglobin was 13, and the patient was planned to have a surgery once things calmed down. And about a few days later, the patient underwent a surgery, had multiple screws placed. So just before the surgery, the patient had a blood count, which showed a platelet count of 96,000, and the hemoglobin had dropped by a few grams. Patient had a surgery, went home. 3 days later, came back in, the fainting episode at home, and was thought to look for reasons of fainting, including a blood count, which showed that patient had dropped the hemoglobin platelet counts even further. Now, typically after any kind of a surgery, it's not common to drop a gram or 2 of hemoglobin, but not so much after orthopedic surgery, but the significant drop in platelets was also unexplainable. Within a few days, the hematology was consulted, and given the prior history of autoimmune hemolytic anemia, the patient received immunoglobulin to treat that, and also transfusion, but then they looked at the blood smear and they realized they saw the schistocytes, the broken down red cells this time, and they also found other features of breakdown of red blood cells, such as elevated LDH, which is an enzyme which gets released when the red blood cells break down. That time, the diagnosis of TMA was made because the patient had hemolytic anemia with schistocytes, low platelet count, and the blood smear was evident of that, and the sent for Adam TS30. And patient took about 15 years from the time the patient was initially thought to have TTP with the diagnosis, ITP with now with the diagnosis of TTP, and the ADAMTS13 activity was low and was subsequently confirmed with the genetic testing. Now, the reason I'm bringing this case is that the true challenges in diagnosis of TTP, so that's what we do to educate people to actually also think about other causes of a low platelet count. And some of you may have spent many years longer with varying degrees of symptoms. So what are the diagnostic opportunities we have in patients with congenital TTP? Newborn period has been well thought to be a time point when the red blood cells can break down. They can get severe jaundice as a result of that. They can also have a low platelet count. This again could be missed because it can mimic infection, especially in a baby. And also sometimes when there's a blood group incompatibility, you can actually have a similar symptoms as well. So it's important to think about TTP. Pregnancy, as we've discussed today many times, especially congenital TTP, can never have any symptom till during pregnancy. They can present with very high blood pressure sometimes, especially in the early part of pregnancy. And other conditions such as infection, like we discussed in the previous patient, the reports of patients with congenital TTP who've presented after an excessive alcohol intake, vaccination, surgery. All these inflammatory conditions tend to increase the von Willebrand factor. They're already at an imbalance of low ADAMTS13. When there's inflammation, there's even more increased von Willebrand factor, which actually makes them more susceptible for symptoms. Now here I've listed a few other symptoms and with some percentages in black from various registries that we mentioned earlier. Headaches, very commonly reported, stroke and TIA. It's interesting that seem to be seen more so in younger individuals, and about 50% of some of these registry have had stroke or TIA as a transient ischemic attack involving the brain, which they can develop even before they are 30 and 40 years of age. And other non-specific symptoms such as lethargy, abdominal pain, recurrent miscarriages is seen in a reasonable number of individuals with congenital TTP. It's important that whenever there's an atypical presentation of ITP or low platelet count, or the suspected family members to consider testing for TTP. So briefly, I'm going to go in the next 10 minutes on the management of congenital TTP. I'll focus on the top two, and we'll talk a little bit about some of the newer agents. So number one, plasma. Plasma is the liquid portion of blood, and it's probably because of COVID, most of you heard a lot more about plasma, but fresh frozen plasma has been used for decades. And the reason we use it, especially for congenital TTP, because it contains the enzyme. So if it's from a normal individual, we expect them to have a normal amount of ADAMTS13. So it's a source of ADAMTS13. So you can use it either two ways. You can use it for on demand, meaning if they're presenting with flare-ups of symptoms. So you already diagnosed with congenital TTP, they're coming with headaches or low platelet count, or stroke or any other symptoms, or they have even more severe symptoms than their baseline, you can actually use plasma. Typically, most of us use around 10 to 15 milliliters per kilogram of the body weight, and sometimes used daily, especially if they're coming in very sick, until the symptoms improve. And you can then adjust the frequency of it. Typically, after about 15 milliliters of plasma, you have ADAMTS activity lasting for about a week is what I usually tell people, maybe a few days longer. The other reason we use plasma in patients with congenital TTP is as a prophylaxis or to prevent them from having symptoms. About 60 to 70% of the registries that I mentioned earlier, be Japanese or United Kingdom and so on, were on plasma therapy for congenital TTP. It's kind of a similar here as well. And the frequency of the plasma therapy in these individuals, about 1 to 3 weeks, an average of every 2 weeks. And many physicians use their symptoms as a way to guide how frequently to give and how much to give. But again, many of these are information that we've gathered to a large extent retrospectively, but to some extent the registries and consortiums like this, we're able to actually gather this information prospectively, which is a little bit more informative. But interestingly, a recent article by the Japanese registry noted that in spite of being on plasma, about 60-70% of those patients, about 40% of them had persistent organ damage, some of it very severe, involving kidneys, brain, and heart, telling us that using plasma regularly not necessarily actually will completely negate the effects of low ADAMTS13. So what does it do? It raises more questions. The question is, when do we start? Do we wait for them to actually have symptoms before we start, or should we start from the time they've been diagnosed? How often do we give? Most people try to use patient in terms of what the symptoms for that particular patient is, so it's more personalized therapy. We again don't know, is there a platelet level that we need to maintain? The reason being is that patients can have symptoms of congenital TTP in spite of what we call a normal platelet level. So when patients have received plasma, their platelet level actually have gone up, suggesting that they're actually having low platelet count, meaning they're getting consumed in this microclots, even though their platelet count is normal. The moment we start giving them plasma, the platelet count goes up, suggesting that that a normal platelet count is not necessarily should make us feel comfortable that they're not having any symptoms. What is the level of ADAMTS13 that we should maintain? Again, it's a big question. Should we maintain a level, a good level before we give the plasma, or are we expecting the levels to go up and maintain at a higher level? And I think, though we have registries, and we don't have great answers to such questions. In United Kingdom and in the USA, there's another factor which is used. It's called COAT in the United States. It's really initially was used for patients who have factor VIII deficiency or hemophilia. Interestingly, this product also has some ADAMTS13. I've listed here how much of ADAMTS13 it has. So it's been used in some individuals. There are some case reports of it as prophylaxis to prevent some other long-term damage. This is kind of the most commonly used dosing. Again, the frequency is very variable between twice a week to every 3 weeks, depending upon where they want to keep the ADAMTS13 level. There's some advantages to it. More importantly, it's probably cheaper. You can do it at home, like many of the patients with hemophilia inject these medications by themselves, or a family member helps it. And usually much smaller volume than the platelets, which are much larger volume. And because, plasma, and most of the plasma, you have to go into the hospital setting because of the risk of allergic reactions. This product is less allergic reactions. So there's some advantages, but at the same time, the amount of ADAMTS13 rise that we get in few days may not be as what we need, because again, we don't know exactly how much level of ADAMTS13 we need. The newer agent, which is the recombinant ADAMTS13, which is a manufactured ADAMTS13. So this study was done by Dr. Scully et al. And what they showed was, again, it was proposed for prophylaxis. It was a phase 1 first in human clinical trial. They tried 3 different doses, and they showed that the higher dose, they did increase the ADAMTS13 within the first hour, which was also related with, they saw a platelet count also go up. So the phase 3 work is ongoing, but it's certainly more promising because we're actually giving the actual ADAMTS13 back into these patients. In terms of the dose, how often do we give is something we're waiting to learn. Some of the novel agents, and I'm kind of going to be very general, is most of these novel agents, such as somebody asked about Cablivy or caplacizumab, they all kind of what I think as something that works in between platelets and this vulnerable factor. Cablivy specifically goes and binds to this portion on the BWF and prevents the interaction with between the platelets and this vulnerable factor. So if, as you saw earlier, these things sticking together, they get longer and longer from clumping. And if you use something which prevents them even sticking together, the platelets are not going to be lower, and there's less chance of forming macroclots. And this can be quite significantly helpful. We know for sure in immune thrombocytopenic purpura, but there are other agents people generally call as anti-platelet agents because they kind of anti-platelet by preventing its function. But this is where the field is going and looking at newer, smaller molecules which can potentially last longer with minimal other side effects such as allergic reactions and so on. So with this is my last slide. I'm going to talk about our presentation. TTP, what do we do at this point? We use plasma. It's still easily available, very effective, and we have most experience too, and even in the remote areas. When somebody is already diagnosed, the recommendation is to consider prophylaxis just because we do not know, and maybe we know that in spite of prophylaxis, people can have symptoms. But there are a few options. We discussed plasma and this CoA8, which has factor 8 in them. I recommend ADAMTS13 as part of a clinical trial, so it's important to be part of clinical trials, and also this registry and consortiums are very valuable in understanding this rare disease. Supportive care, as was in the previous talk that you heard about, importance of regular visits to the primary care doctor in addition to the hematologist, healthy lifestyle, minimizing additional injuries to the organs such as avoiding smoking, etc. I'm sure the gene therapy is rapidly changing how we actually treat not just cancer, specifically non-cancer blood disorders or benign blood disorders, what we call as. And that certainly will go into TTP as well. There's been some early studies in animal models, not that I'm aware of in any humans, but that is exciting. They're looking at ways to actually introduce a normal copy of the gene into a cell of that patient and give it back to the patient. So thereby they tend to make normal amount of the ADAMTS13, so they would never have to receive any of the issues in the future. But none of these will be possible without involvement in the registries and clinical trials. So with this, I'll end my talk here. And if anyone is interested, the patient I discussed earlier was initiated on plasma as prophylaxis for every 2 to 3 weeks while we're waiting for the recombinant ADAMTS13 as kind of an extension study for this particular patient. With this, thank you.
All right, and at this time, we'll have our panelists come up there. We'll have a discussion and questions. One of the first questions is going to be about the likelihood that the congenital TTP could be passed on to a child, and whether it would be safe for someone with congenital TTP to have children.
Yeah, it's a great question. It's important in terms of genetic counseling, and we do try to, at least in our place, again, these are rare disorders, we do try to include the genetic counselors to discuss such things. I think the most important thing is what kind of genetic defect that the parent may have. First and foremost, yes, you can have children. Like with immune TTP, it's very important to work very closely with obstetrician and also sometimes the fetal medicine specialist, depending on where you plan to have the child, in addition to a hematologist who's comfortable with TTP, not just with other blood disorders. So that'll in itself will help in improvement of care. And we usually recommend that, again, especially in certain kind of mutations, what we call as a biallelic mutations, we definitely recommend testing the children as well.
All right, and if you guys want to go ahead and just introduce yourselves, you should be able to speak loud enough so you don't have to use the hand mics too. So.
Okay.
I'm Aaron Metchin, hematologist at the University of Colorado in Denver.
I'm Spiro Catalan, the hematologist at Ohio State University in Columbus, Ohio.
All right, we also had a question about CoA8 and if it's able to be utilized for non-congenital TTP patients, so for acquired. So if you guys just want to speak to the difference in the treatment of the two and why that would, why there would be a difference there.
You know, in the upcoming session, I'll talk about sort of the treatments. We'll go into that in more detail. But like Satheesh said, the real difference is the congenital form, you don't have that protease, so you have to add it back. And that can be plasma. It can be CoA8, which is a plasma product that has some ADAMTS13 in it, just like red cell transfusions have some small amounts in it. Or it can be the clinical trial that's ongoing, the recombinant, so where it's made in the lab and given directly to the patient, where you can control the dose and can understand the effect you're having. In the acquired form, you have an antibody. So we call it the acquired form, or the term we use now is immune-mediated TTP. So in this case, you are born with the protease, you develop antibodies against it, and the antibodies can either bind to it and clear it like you don't have it, or it can bind to it and make it not work like it should. So in the congenital form, you're giving the protease. In the acquired form, you're trying to remove the antibodies that are causing the problem. That's the plasma exchange, steroids, rituximab, and your own body will just continue to make the ADAMTS13. So one, you don't have it. One, you have it and it's being cleared by your immune system. Anything? Makes sense.
There is, along those lines, there is a clinical trial that is ongoing with the use of the recombinant ADAMTS13 in patients with acquired TTP, along with the obvious with congenital TTP. So currently, we would say that there is no good evidence that would support us to use plasma or coate in patients with immune TTP.
It was discussed that this diagnosis can occur later in life for congenital TTP. How would somebody who has zero ADAMTS13 activity survive to be diagnosed later in life? And why are they not just constantly having issues?
That's pretty good. Yeah, that's a great question. I think I wish I had a clear answer to you in terms of why some present later. It could be a number of factors. We know there's certain modifiers of disease, what we call as, so inflammation, infection is one of the modifiers. And it could be that it was not to an extent that really affected you to have symptoms. Sometimes symptoms are so mild that you might not think this is really a medical symptom. You could be just thinking that I had a really bad day, I'm just tired from that. And people try to attribute symptoms to various other reasons as well. It could be, or it could be convinced it's actually not anything abnormal with you as well. And it could also be that we know the levels of ADAMTS13 is not hugely different. There's not a great evidence that what kind of genetic abnormality or mutations or change in the actual gene can that predict how well you present. There may be some developing data on that. At this point, to my knowledge, there's not any a good reason to say that if you have this kind of a genetic mutation, you may not present late. But I think we're learning more on that. But like I discussed earlier, that pregnancy is one condition as well, where they tend to have a lot more production of this one factor. So these specific conditions, why they may just not even present until later in their life. The other modifiers, such as immune system, how the immune system is wired to respond to such things as well, which could potentially be help in defining why some of these patients, even both with the immune TTP and congenital TTP, could actually have a varying presentations. I'll ask my other panelists for the thoughts.
I think an important point, if we talk about the immune mediated, to go back to congenital. And one thing you have to understand is that if you have low ADAMTS13 activity, it doesn't mean you're automatically going to relapse. It's a risk factor, but it doesn't mean you're automatically going to do it. And a lot of the research that's been done in animal models, mouse models, as well, we've seen in clinical research, shows that just being low does not mean you automatically relapse. And I think the best example of this is a study done by the French, where they looked at every patient with the immune, the first presentation was thought to be immune TTP. And they looked at females who presented at the time of pregnancy, where we know it is a strong risk factor for triggering TTP in congenital TTP. And as you just heard, congenital is a very rare disease, but I think it was 29% of patients who had women with their first episode actually ended up having congenital TTP that were found later to be congenital. So they lived their entire life not knowing they had this, but it took that second hit of being pregnant that triggered it and led them to the awareness of the diagnosis. So it's actually getting to be 60 or 70 is a bit rare, but getting into early adulthood and not being diagnosed with congenital TTP can certainly happen. It can be misdiagnosed as something else. But again, I think you have to remember, just the low activity alone does not automatically mean relapse. in immune mediated, and therefore in congenital, low activity doesn't always bring a severe episode to the clinician's attention. What do you think? It's an interesting question.
Yeah, it is. It's a great question because this is, if you were flying the wall with many of these TTP conferences, this is one of the things that we've talked about is that ADAMTS13 deficiency is necessary for the development of TTP, whether congenital or immune, or severe ADAMTS13 deficiency, but it's not sufficient. We know that there have to be other things, and what those other things are, if it's one thing, two things, 8 things, just based upon the complexity of hemostasis within the body, we still don't know what that is. Is it von Willebrand factor levels? Is it ABO blood typing? Are there other factors that anchor ADAMTS13 to the endothelium? Is it other things like shear and cardiovascular risk factors? We don't know. But that is just what we've observed, that there are people that will present only in their 2nd or 3rd decade of life, and they are not in a constant state of a thrombotic microangiopathy.
So one question that I commonly hear from physicians and also from families is that in patients who are being actively managed with prophylaxis with congenital TTP, in an attempt to measure the effect of both plasma or CoA, is that when the level of ADAMTS13 is checked shortly after the preventive treatments, we still can't find ADAMTS13 measurable in the blood. Can you speak to why these treatments work if we can't measure the enzyme? And any thoughts as to why we can't?
Interesting question. So as much as we know about congenital TTP and immune-mediated TTP, there's a lot of things that we just don't know. And I think if you ask 20 experts, what is the ADAMTS13 activity you want to reach in a congenital TTP patient, they'll shrug their shoulders and say maybe 20, but we don't know. We also don't know how much ADAMTS13 somebody is getting in each unit of plasma because it comes from different donors. And there can be variability between donors. You can have somebody be a carrier, meaning they just carry a mutation of the ADAMTS13 gene, and they may have lower levels. So there's going to be levels with each donor that are different. How each patient reacts to it is going to be different. And the advantage of a recombinant ADAMTS13 is you can actually now know the dose you're giving, and you can then measure it at routine time points, which is what's happening in these clinical trials. And once we know for the first time the levels we can achieve, then you can look at clinical endpoints and say, this patient did well, what was his or her level over time? This one had some complications, what was his or her levels? And then you can start to learn. But I think we still have a long ways to go in terms of understanding it.
You mentioned registries, a few of the registries. Can you speak to what it would take for a patient to get involved with one of those and how to do it best if they were a congenital TTP patient who wanted to get involved?
Yeah, they're all available online. I'm not mistaken, there's the international registry, and I believe Oklahoma also has a registry for patients with congenital TTP. They will be more than happy to enroll anyone who is interested in participating. And actually, we recommend that. We ask that people volunteer to do that because this is what gives us information. This is what helps us with the next patient who has questions or has been re-diagnosed with congenital TTP.
I think you're going to see, so any questions that patients or families have about registry, reach out to our consortium and we'll get you in contact with the group at Oklahoma. That is the arm of the international study in the US to enroll.
What does it take to be part of these registries? Are they going to have to do a lot of traveling? What exactly does it entail?
No, I mean, it's quite easy. After an initial discussion, your name and contact information is passed on to the group at Oklahoma, and they will consent you over the phone and or online. Genetic testing is not required to get into the study. If it has been done, they'll get the reports. If it's not been done, they'll provide a mechanism for you to get that testing done by the group in Switzerland. So it's really as easy as reaching out to our consortium to get you in touch with the Oklahoma group, which can help out from there.
So in patients who have comorbidities like heart failure, and I assume there's other options, heart failure is one listed, can plasma exchange or plasma infusion cause volume overload? And if so, especially for congenital TTP patients who are getting frequent plasma infusions, would the recombinant ADAMTS13 be seen as a benefit?
Yeah, no, it's a great question. I think volume overload remains one of the challenges, just in congenital TTP, in any conditions where we're giving plasma, especially because we base this amount of plasma on the body weight. And especially with heart failure, the reason you're asking and the benefit of others, that there's already a load on the heart. So if you actually add too much volume, the heart will struggle to pump blood out, and that can actually make the heart failure worse and also affect the lungs. So in those individuals, a great question. If it's possible to consider getting become ADAMTS13 would be fantastic. But if not, I think it's very important to even consider smaller volumes of plasma infusion at more frequent intervals, so that you can manage the volume. More so, as importantly, is to have a team who follow you very closely, talk to each other, such as the cardiologist, the hematologist, and also the transfusion doctors, who can potentially be able to kind of give you an idea of the plasma. But yes, it is already a rare condition, and you'll be taking it to a different level of being rare and increasing challenges, but it is doable. The key is to also might need more frequent monitoring of the ADAMTS13 enzyme level, even though we don't know exactly where to keep it, but it's certainly worth in this particular cases.
I would even I'll take one step back just so everybody understands the difference. As Satheesh has been talking about, when we talk about plasma therapy for congenital, it's just an IV in the arm, and plasma is just infused like a blood transfusion. Plasma exchange requires the catheter go into a large vein. It needs to be a larger, stiffer catheter because the machine has to pull off plasma, and the machines, I'll show you in a slide in the next session, how it can separate the liquid part of the blood and then the plasma is added back. So the main difference with exchange is you're not less plasma volume you're getting, because you're kind of removing what you're putting in. And with immune TTP, you're also removing the antibodies. So you could do plasma exchange for congenital. It's just a lot more effort. It's not required because you don't need to remove antibodies. But the volume is an issue. You have to be careful, as Satheesh said, with plasma infusion.
An option, if the heart failure is severe enough, where someone with severe heart failure who's very sensitive to extra fluid administration, then the medication like CoA that was mentioned, which is a medication that's used for hemophilia. It's plasma derived, has high levels of ADAMTS13. That can be an option. And of course, we would recommend, if possible, I'd recommend considering enrolling in the recombinant ADAMTS13 trial for congenital TTP, because that would answer our next question: is would this be more beneficial? Is it a lower volume? Would it be able to provide ADAMTS13 replacement that would be more effective and safer than just plasma infusions alone? So those would be two other, in addition to plasma infusions, plasma exchange. Someone could consider CoA and could consider enrolling in the recombinant ADAMTS13 trial.
And I know that the data is pretty limited for the recombinant ADAMTS13 as it's just now being studied. But we have somebody wondering about the allergic reactions with plasma versus the allergic reactions with the recombinant ADAMTS13. Are you guys aware of anything you can speak to?
So there are options with plasma for someone who has severe reactions to plasma. Before, the options were either not give it or heavily pre-medicate someone to try to reduce the effects. There are there is an alternative plasma compound that is out that's made from pool donors. So usually people react to, if they're getting a dose of plasmids from one person, and if that person had peanuts or was having an allergic reaction or their hay fever was or whatever, they can react to whatever was in that single donor plasma. But there is a plasma replacement that is made by pooling 800, 1,600 units together, donors together, so the risk of allergic reactions is less. I have to confess, I'm not familiar with how much ADAMTS13 is in that, but it is a FDA-approved plasma alternative known as Octaplas. But as for the reactions to recombinant ADAMTS13, as of yet, I'm not aware of any increased reactions or allergic reactions to it.
No, it's a great question. I agree. For example, in the United Kingdom, they primarily only use the Octaplas, which is the detergent wash plasma. And they definitely have less allergic reactions. And in terms of reactions to recombinant ADAMTS13, to my understanding, they haven't found any antibodies against this recombinant in the clinical trial so far.
Is there anything a congenital TTP patient should be doing differently in a COVID world? Do they need to be worried about an increased risk of a TTP episode due to COVID, either the infection or vaccine? And would you recommend they get vaccinated?
I don't think they should be treated any differently than any of their other friends they go to school with. Same thing, like in higher risk situations, masking, vaccination should be equally safe and it should be equally effective. I don't think am I missing any caveats why you shouldn't?
I don't think so. I think especially since children, most of them may not be eligible for vaccine, at least at this point, since they're less than age 12. I think ensuring the parents, caregivers are vaccinated to minimize the risk, and also wearing masks at school will make hopefully a difference.
How often should congenital TTP patients be seeing a hematologist, and how often should they be getting blood counts of whatever variety, and what would you recommend?
Yeah, no, I think it's a great question. It is very variable, so I'll give my answer. I think we try to see them more frequently, probably because the child, we tend to do that anyway for most children with any of the chronic disorders in pediatrics. I generally recommend at least every 2 to 3 months, especially initially. More initially is usually more weekly, and then once we have an idea about how the child is doing, the key is to maintain the rapport and have an open line for the parents or families to let you know if the patient is having any symptom, because that's what you really want to know, is the patient having any symptom. Oftentimes, family members are fantastic if this child is not really doing well to give you a call, but the key is to know, are there symptoms that they're not thinking they're important to let you know? So those are things that you may want to let them know to inform you. But I think in terms of blood work, I think more frequent than every 3 months if the child is stable. I don't think there's huge utility, because then you're just chasing those numbers rather than how you're going to relate to the particular child.
Yeah, there are some patients with congenital TTP that only get in trouble after an infection. So they may have enough ADAMTS13 that they don't require ongoing treatment. I think it's safe to say the majority probably do, and at least in the adult world, the treatment frequency of the infusion is a negotiation between, based on the blood counts, how often we think they need it, and how often the patient will tell you they're willing to come in. I think there are certainly patients that we think should be on weekly infusions, and because of the time, the inconvenience, the answer you get back is no, I just can't do that. And this is a long-term chronic issue, so you deal with it that way. I think where the real benefit of the recombinant ADAMTS13, if it becomes FDA approved in the future, is that you can treat people more frequently, very much like people are treated at home with hemophilia, where they infuse themselves. So patients with these congenital deficiencies of clotting factors will treat themselves at home with IV. Some patients with coate do this at home. So once we have something that can be more easily given at home, giving a blood product at home is just very difficult and maybe even dangerous to do. But this would be easy to do. So you could have a patient dose at home once a week, twice a week if needed. It would be still cumbersome, but less cumbersome than coming into a clinic for a 4 or 5 hour experience. What do you think is a blood bank?
I think it's easier in the adult world because you can have this conversation with someone who's now been presumably living with this for several years and they understand what they're feeling. The person knows what they're experiencing and can vocalize this and can tell you something's wrong. Many of our TTP patients will tell us even before the number sets out, like they know that something's going on. At the least, I've wanted my patients to see me at the very least once a year, just so that they're not lost to follow-up, that we're checking in case there's something new, changes, we're able to keep a pulse on things. And depending upon the tempo of everyone's different, and depending on the tempo of their condition, we may increase that to twice a year, every 3 months, monthly, as just in terms of while we're checking in on that person. So I don't think it's a one size fits all. You sort of measure it to the person and go from there. And I think that's our advantage in the adult world, is that we have patients that can tell us that something is wrong. I'm worried that my TTP is relapsed, and we can have them come in and get labs checked or follow up on their treatments.
Great. And any questions that weren't answered, we will follow up with in our Ask the Hematologist session. Any questions that you want to ask that you may have missed the opportunity to, feel free to put them in the Q&A and we will get those answered later. Thank you to our panel.